presented to the emergency department with cough, fever, and difficulty in breathing for 10 days duration. Right. So this is the chest X-ray taken in the emergency department. Okay. So now with the given history and all that, so what is the radiological diagnosis? So if you are given this chest X-ray, or something like that, so what is the radiological diagnosis? So what are the abnormalities you can see?
Homogeneous opacification in right lower lobe and right lower zone and upper zone also. There is some opacification in right upper lobe zone.
Okay, so shall we ignore that? The upper zone one, we can, shall we, for the time being, shall we ignore that, right? So radiologically, there seems to be a opacification involving the, you said right lower lobe, right? And so why do you say it is right lower lobe involvement? So in a chest X-ray, how are you going to find out whether the lower lobe is involved?
A diaphragmatic silhouette sign.
Okay, so you cannot see the diaphragmatic borders very clearly, right? So if you if the right heart border is obliterated, then it's the right middle lobe, right? If the diaphragm is obliterated, then it has to be right lower lobe, right? So apart from the homogeneous opacification and all that, anything else?
Meniscus sign.
Okay, meniscus sign, very good. So that is a sort of indication of what? That indicates
Pleural effusion.
the patient is having a pleural effusion. So if it is a very tiny small pleural effusion, so what would happen? What would be the initial kind of picture? Very
obliteration of the costophrenic angle.
First, it will start with obliteration of the costophrenic angle, right? So now to detect a pleural effusion on a chest X-ray, how much fluid should accumulate in the pleural space? Roughly
300 milliliters.
So usually it is 300 milliliters, and clinically it has to be
500.
500.
It has to be 500 milliliters, right? 500 is fairly large amount, right? So till then you will not clinically detect the
300 milliliters.
I didn't hear you clearly. Right, 300 milliliters chest X-ray, and clinically it has to be 500 milliliters, right? Okay, now if the patient is having right lower lobe consolidation, what other physical, what are the other X-ray findings you might see? So if someone is having a right lower lobe or right middle lobe or any consolidation, apart from homogeneous opacification, any other thing which you are going to specifically look for? So yeah, bronchogram, right? Yeah, bronchogram, very good, right? So in between the homogeneous opacification, you will see the air-filled bronchograms, right? Air bronchograms will be there. So that is a classical feature of consolidation, right? So if you are given a chest X-ray like this, and if someone asks what is the what is the radiological diagnosis, what is your answer? So in this chest X-ray, can you exactly say that the patient is having consolidation?
No.
It's very difficult. It's very difficult to say there is consolidation, but you can straight away say there is a right-sided pleural effusion. So the postophrenic angle is obliterated, and then there is this meniscus sign as well. Right? Okay. So radiological diagnosis, probably without the history and all that, probably it would be right-sided pleural effusion. Right? So what would be the complete diagnosis? So given the history, chest X-ray, right? And given the question, so what is the most likely complete diagnosis? Oh, someone should answer. So you will have to answer, because the way the things are happening, we might have to continue this medical education through Zoom forever, I think. The way the things are happening in Kandakadu and all that, right? So you will have to answer.
Pleural effusion due to tuberculosis?
So 10 days history and all that.
Right-sided pleural effusion followed by right lower lobe pneumonia.
Right-sided pleural effusion followed by right-sided pneumonia. So what may be the first thing which might have happened? Pleural effusion or
Pneumonia.
pneumonia. So then, is there a name for a pleural effusion which is happening after a pneumonia? What do you call that?
Pneumonic effusion.
Right, parapneumonic effusion. So patient is basically having a right-sided parapneumonic effusion, right, due to right BSL pneumonia. Yeah. So then you can easily explain the pleural effusion as well as the pneumonia part as well, the cause behind the cause which has led to the pleural effusion. Right. So in a ward setup, so this patient is having fever for 10 days and all that. So can you list clinical features you would expect to see in this patient? So just imagine we have to go to the number one, we have to go to the, first we have to do a general examination to find out whether the patient is febrile and all that, right? And this patient is having right-sided lower lobe pneumonia with a parapneumonic effusion. The patient should have fever, and patient should have a cannula inserted for IV antibiotics, right? And then the patient should be lying on the bed. Maybe patient may be on general examination. Patient comfortably lying on the bed or something else. So patient might be propped up. Very good. Anything else?
Dyspneic and uncomfortable.
Okay, uncomfortable, dyspneic, and anything else? When someone is dyspneic nowadays, we
Tachypneic.
tachypneic. Okay. Anything else?
Oxygen delivery.
Patient may be getting oxygen. Before giving oxygen, we have to check something.
Pulse oximetry.
Right. Okay. So patient may be attached to a pulse oximeter, and the oxygen saturation may be on the lower side, on room air. So that may be the reason why people have started giving oxygen. Right. So you go to the foot 10, isn't it? And you ask the patient to take deep breaths in and out. So now the patient is having right-sided pleural effusion. So what might you observe?
Reduced chest expansion of the right side.
Very good. So the chest expansion will be reduced over the right side, right? And then you go laterally, right? And then you specifically look at the epicells, isn't it? Whether there is any apical flattening or not, right? Number one, you start with the foot 10. You very carefully you have to observe, and you have to, like a cricket, like a third umpire, right? You have to check both sides simultaneously and find out whether you have to compare, and you have to find out whether there is any abnormality in a particular side, right? Then you go laterally and you look at the epicells, isn't it? You check whether the epicell, if there is any evidence of apical flattening. Okay, right? And then what is the next step? Respiratory system examination. So then you have to check where the trachea,
midline or not.
right? Where the trachea is, you have to check. Right now, suppose now this patient is having a right-sided pleural effusion. So if it is a fairly large pleural effusion, what can happen to the trachea?
Trachea deviate to the left side.
So trachea is deviated, can be deviated to the left side. So in a patient with not in this patient, in a patient with a moderately large right-sided pleural effusion, still the trachea is deviated to the trachea is in the normal position. How are you going to explain that? Pleural effusion is complicated with what?
Lung
Right.
collapse.
So lung collapse or lobar collapse. So if it is associated with a collapse, then even though the patient is having a large pleural effusion, still the trachea may be on the normal position. Right? Okay. So then what are you going to do?
Vocal resonance.
Before that, respiratory rate. Okay, you should have done that during general examination. Anything else? Keep our hands over the chest and
Reduce
check for
movements.
Huh? All right. Chest movements. We have to check whether chest movements are equal and equal on both sides. Right. So you might find out that the chest movements are reduced over the right lower sole. Right, in this patient. Right. Then you have to check vocal resonance, and you have to do the you have to do percussion as well. So what would happen to vocal resonance in this patient? So imagine now you are examining the patient posteriorly. What would happen to the vocal resonance or vocal fremitives? Sorry.
Reduce.
So the diagnosis is something like parapneumonic pleural effusion, isn't it? Right, parapneumonic pleural effusion. So then there may be an area of consolidation as well. Right, and there may be a pleural effusion as well. So vocal fremitives will be reduced over where the pleural effusion is. Right, so just above the pleural effusion, sometimes you may detect a area where there is increased vocal fremitives. Right, so in this patient, it's not a purely simple pleural effusion, parapneumonic pleural effusion. So there may be area of consolidation followed by pleural effusion.
Yes, sir.
Okay. So because of that, there may be area of dull area followed by stony dull where the fluid is accumulated. Right. So on auscultation,
Absent breath sounds.
okay, absent breath sounds. Anything else?
Bronchial breathing.
Right, bronchial breathing just above the level of the pleural effusion. So as there is consolidation, anything else you want? Bronchial breathing and any added sounds?
Crepitations.
Post crepitations. And if the pleura are involved, patient might have pleural rub. Right, and in addition, you have to comment about the vocal resonance as well. Right, just to refresh your knowledge about, I added this question just to refresh your knowledge about examination of the respiratory system. Right. So now this is a patient. Now patient has come with cough and fever and all that. Right. So the emergency department, they have done an X-ray. So it looks like some kind of consolidation plus pleural effusion. So what are the other investigations you want to do on this patient? Meteorological investigation and other further investigations.
Full blood count.
Okay.
CRP.
Okay.
Serum electrolytes.
Sputum culture and ABST.
Okay. If the patient is producing sputum, yes, of course, sputum culture and ABST. Anything else? So just full blood hematologically, full blood count. So you cannot prick the patient, keep on pricking the patient, right? So you have to take blood. So you do a full blood count, CRP. Anything else you want to do? So when you are asking for this, yes, sir, you can do. Anything else?
Blood urea.
Okay, blood urea. So you are going to assess the severity. Blood urea, good.
Serum albuminal lactate.
So yes, so, right. So you have to do serum total protein and albumin as well, right? So that may be helpful for further testing on this patient. Anything else?
LDH level.
In addition, this patient if the patient is really looking and all that, so you can do blood cultures, right? And you can ask for liver functions as well, isn't it? So right, lower lobe involvement, right? Sometimes may be due to secondary due to liver involvement like amoebic fever abscess and all that. So better to do SBOT, CPD as well. But if you do that, you have to defend. Yeah. So you have to tell why you are going to do that, right? Like blood urea and serum creatinine. If someone jumps and asks, why do you want to do blood urea and serum creatinine? You say, I want to assess the severity of this pneumonia, right? So obviously, then according to the curve 65, we have to check blood urea, right? So inflammatory markers, full blood count, CRP and ESR and all that, right? Anything else you want to do?
Sir, is ABG's need for this patient?
Yes, ABG, yes, of course, if the patient is tachypneic and all that, and if the patient is dyspneic and oxygen saturation with the pulse oximetry, if it is low, we have to do a arterial blood gas as well, right? Okay, so but at the moment, blood patient is stable, right? Having a right-sided pleural effusion, parapneumonic pleural effusion. Any other investigation you want to plan? At the moment, patient is not that dyspneic, even though the patient is febrile.
Pleural fluid analysis by
pleural fluid analysis. Right. So what are the investigations you want to do on pleural fluid you have drained?
Cell count, gram stains, acid fast bacilli, glucose and culture.
Okay, you do culture. You started with what?
Gram stain, sir.
Gram stain. Okay, we have to do that. And then you have to look for acid fast bacilli. Good. Anything else?
Proteins and LDH.
So you have to do protein and LDH levels.
Glucose and cytology.
Glucose, and you have to ask for cytology, right? Cytology, and then the cell count and cytology as well, right? Cytology, you look for malignant cells and all that. Cell count, and ideally speaking, you have to use a EDTA bottle, and you have to check the total white cell count and the differential count using a EDTA. We taken into a EDTA bottle, right? Cytology, right? Actually speaking, if you are looking for malignant cells and all that, so these cells can get easily destroyed, and because of that, you have to use a special liquid containing containers to send samples for to look for malignant cells and all that, right? So you need to have a special transport media for that, right? So now you have started taking this thing, right? You have done a diagnostic pleural aspiration, right? And the aspiration is blood stain. So what are the possibilities?
Could be trauma or tuberculosis, pulmonary embolism, or malignancy.
Okay, now number one, so it may be trauma. So out of malignancy and other things, malignancy, what else?
TB, pulmonary embolism.
Pulmonary embolism, right? TB යටට යන්න ඕන මම හිතන්නේ. TB යටට තියලා you first number one, it has to be something like malignancy, then something like pulmonary embolism, and then lower down it can be even due to tuberculosis as well. Right? It can be due to tuberculosis as well, right? So if it is something like a sort of kind of a thing, so you have to think about empyema, right? Empyema. Okay. Right, and then okay, cytology. Now cell count. Now you have done a sort of a total white cell count and a differential count, and total white cell count is predominantly neutrophils. What does that indicate? So if the cell count predominantly neutrophils, something like 90% neutrophils, what is the possibility?
Bacterial infection.
It's usually due to bacterial infection, right? So if the lymphocyte count is very high and 90% of cells are they are lymphocytes, so what are the possibilities?
TB.
Tuberculosis, and anything else you want to consider?
Malignancies.
Malignancies such as
The lymphoma.
lymphoma, right? Something like lymphoma. So tuberculosis and lymphoma. And sometimes if pleural effusion can be due to a pancreatitis as well. So in some instances, people check serum amylase level as well in the pleural fluid. So if the amylase content is elevated, then it can be due to the etiology may be pancreatitis, right? Okay. Okay, so now these are the investigation results. So in this patient, hemoglobin is 13.2, total white cell count 17,200. This is peripheral blood, right? Platelet count 442,000. CRP, ESR high, serum protein, LDH levels are given. Appearance is turbid, and LDH value is given, and protein is 38. Can someone interpret these results?
His inflammatory markers are higher, including white blood cells, CRP, and ESR, indicating
Right.
there's acute bacterial infection going on.
Right. Okay. So it looks like a bacterial kind of a infection, isn't it? Right. So how are you going to interpret the pleural fluid analysis report?
In pleural fluid analysis, pleural fluid to serum protein ratio is 0.77. That means it's more than 0.5.
Mm-hmm.
And pleural fluid to serum LDH ratio is 0.9. That means it's more than 0.6. And pleural fluid LDH is more than 2/3 of upper limit of serum LDH. So, according to Light's criteria, this is exudative type pleural effusion.
So it looks like exudative type pleural effusion. And the pleural fluid again, protein level is also more than 30, right? It is more than 30 grams per liter. So again, that is indicating that this is a exudative type pleural effusion, right? So that is a sort of perfect answer which I was expecting. So you mentioned about inflammatory markers in the peripheral blood and all that, and then you one by one you told about serum LDH protein and the ratios and all that. So for you to get in a sort of a SCQ type of question, so you have to mention all those aspects to get full marks, right? Like according to like criteria, this clearly you will not be able to get full marks for that particular answer, right? Make you right? Okay, and then so are these results compatible with initial complete diagnosis given? So that was right-sided cell pneumonia leading to parapneumonic effusion. So is it compatible with the answer you gave? Are the reports compatible?
Yes.
With? Yes. Right. Yes. So in the parapneumonic effusion, again due to you would expect to see high inflammatory markers and all that with a short history and fever and cough and all that. So in addition, you would expect to see a exudative type pleural effusion. Right? Exudative type pleural effusion. So what are the causes which would give rise to transudative type pleural effusions? Causes for transudative type pleural effusion.
Heart failure.
Okay, congestive cardiac failure.
Cirrhosis and nephrotic syndrome.
Nephrotic syndrome.
Cirrhosis.
Chronic liver cell disease.
Hypothyroidism.
I didn't get you. Hypothyroidism.
Meiggs syndrome.
In Meiggs syndrome, again, Meiggs syndrome, it's a malignancy kind of thing. To expect to see an exudative type of pleural effusion, but it causes a transudative type pleural effusion, right? Then something to do with heart again.
Constrictive pericarditis.
Constrictive pericarditis. Something to do with SVC. SVC obstruction, again due to increased pressure, isn't it? So SVC obstruction, constrictive pericarditis, congestive cardiac failure, right? Meiggs syndrome, nephrotic syndrome, chronic liver cell disease, all can lead to transudative type pleural effusion. So what are the causes? List five other causes which would give rise to similar pleural fluid analysis results. Again, exudative type.
Tuberculosis.
Okay, tuberculosis.
Malignancy like lymphoma.
Malignant pleural effusions. Okay.
Bacterial infections, SLE, rheumatoid arthritis, pancreatitis.
Mm-hmm. and pulmonary embolism as well. And pulmonary embolism as well. Right? So in the exam setup, during your short cases, this pleural effusion will pleural effusion is a very common kind of short case, right? And right. Okay. So in the short, during your short case, you have to examine the patient in a logical sequence, right, with a perfect technique, and then you should be able to detect a pleural effusion. Right? You have to do that. Okay. And once you detect the pleural effusion, then they will ask about the size and all that, and this all this deviation of the trachea and how to assess, check whether it is a mild pleural effusion, moderate or severe pleural effusion, and all that. And then people will ask you questions about causes and how to differentiate exudative type pleural effusion from a transudative type pleural effusion. So it is a දැනගෙන හිටව හරි ලේසි. So if you detect the pleural effusion, you should be able to get more marks if you answer all those questions. Right. Now this patient, then he was treated with IV coamoxiclav and oral clarithromycin. So this is normally how we treat pneumonias. Right. However, his condition did not improve and fever was persistent. So then what I'm going to do now? So obviously you do a chest X-ray. Right? Obviously you do a chest X-ray. So this is a chest X-ray. So what is the complication this patient might have developed?
Encysted pleural effusion in left side and the normal pleural effusion in right side.
Okay, right. So there's again even in the right side, it looks like encysted, isn't it? Going right up to here. Not only on the left side, right? Even in the right side, patient has developed an encysted pleural effusion. So encysted pleural effusion, is it going to happen in exudative type of pleural effusions or transudative type pleural effusion? So is it going to happen, this fibrous strand formation and all that, leading to for the pleural fluid to accumulate in compartments? Is it going to happen with the exudative or the transudative? So to all these septae to appear, do you need more proteins or less proteins?
More proteins.
So you will obviously need more proteins, isn't it? Right? The patient needs more proteins. So then only all these strands can be formed, and then the pleural fluid will accumulated in small compartments. Right? So that is going to happen in. So if you do not treat the patient adequately right at the beginning. Right? So in addition to that, the patient could ultimately end up having empyema as well. Right? So if the patient is, if a pneumonic patient, it is still, even after treating for more than 3 days, right? If the patient's fever is persisting and the white cell and the inflammatory markers are high, then you have to always think about empyema, especially if the patient has initially have, if the patient has had pleural effusion, and then you have to think about lung abscess formation as well. So those are the two complications following pneumonia, which could give rise to continuous kind of fever with high inflammatory markers, even after adequate treatment with antibiotics for at least 3 days. Right? So if the patient is not responding. Right. So then now the patient is fever is not responding. So what do you want to arrange? So
Ultrasound guided drainage of.
Right, very good. So you will not be, if it is a sort of an insisted pleural effusion, you will not be able to just take a fluid sample. It's better to arrange ultrasound guided pleural aspiration. Right. So we have done that. Culture but pH is 7. Gram stain, now there are gram positive cocci. Microscopy field full of pus cells. So what does this indicate?
Empyema.
Empyema, right? Looks like empyema. Now, even right at the beginning, so patient, whenever there is a patient with a exudative kind of pleural effusion, right? So we must always think whether we have to think about how to treat that, right? So there are certain indications to put a IC tube in to drain the exudative type pleural effusion, right? So what are the indications? If the pH is less than 7 or 7.1 or 7, right? So then definitely that indicates that there is a high chance of patient developing encysted pleural effusion leading to empyema and all that. So you must always put a IC tube and arrange a IC tube drainage of that particular pleural effusion, right? If the pH is less than 7.1. If the gram stain positive and the appearance is really like you are draining a lot of pus and all that, again, that patient need a IC tube drainage, right? If the culture is positive, again, that is an indication to put a IC tube. Okay, so you must. So even when you are doing for the first instance, when you are doing the pleural aspiration analysis, so you should ask for pH, gram stain, culture, and all that, right? Then you have to check the appearance as well. So if it is really pus you are draining, so then definitely then and there you have to go ahead with the IC tube drainage, right? Otherwise, what would happen is all these strands can appear within the pleural space, and in the pleural fluid can be really accumulate within the compartments. So ultimately, patient will have empyema, and then it will be very difficult to get the lungs to re-extend to the original position. Right. Okay, so what is the complication he has developed? Encysted pleural effusion and empyema. So what is the next step in management? pH less than
IC tube drainage.
IC tube drainage. Right. So now you try to put the IC tube drainage into this patient. So somehow you did that, and just hold on for a minute. Right. So now, so like in this patient, now this patient has developed in all encysted pleural effusions and empyema, right? So but it drain only a small amount of fluid. Even the repeat chest X-ray, there is evidence of encysted pleural effusion. So what is the next step? What is the next investigation you want to arrange?
Pleural biopsy.
Oh, no. I didn't hear you clearly.
Pleural biopsy.
Pleural biopsy will be really difficult with that. So now you pleural biopsy, you need to have adequate amount of fluid within the pleural space, right? Otherwise, you can puncture the lung as well, right? So I'm just concentrate only about this empyema and encysted pleural effusions. So now you are treating the patient but not improving, and lung is not expanding. So patient will have short-term and long-term issues with that.
CT scan.
So obviously we have to ask for a CCT chest, right? So you have done that, and again there is evidence of empyema and encysted pleural effusions. So then what are you going to arrange? So how are you going to relieve all these strands and all that? Can we do that in our medical ward? Bad? What can we offer? So is there a way to all these dissect and drain and is there a way to look at the pleural space and clear that area? Huh?
Thoracoscopy.
Thoracoscopy. Now we are in the 21st century. So what do we have to? How are you going to do that?
Video assisted thoracic
So
surgery.
there is something called VAT, isn't it? There's something called video assisted thoracoscopy, right? So basically in that scenario, we might have to send the patient to Valisera to get that done, right? Video assisted thoracoscopy. Currently, right? So again, now you should know when it comes to exudative type of pleural effusions, right? So you should be able to list causes which could give rise to exudative type pleural effusions. And then just by looking at the pleural analysis report, right, you should be able to differentiate exudative type pleural effusion from transudative type pleural effusion, right? Before that, as house officers, you must know exactly how you are going to send samples and how you are going to what the investigations you are going to request for, right? Like pH and all that, right? The moment you see the pleural fluid analysis report, then if the pH is low and if it is exudative type of pleural effusion, you should very carefully look for an indication for an IC2 drainage, right? So if you delay that, you will be in trouble because the patient would develop all these septae and all that, and the patient will end up having encysted pleural effusions and all that, right? Lead into empyema, and then you might have to that will create a lot of unnecessary problems, right? Sending a patient to a particular unit to get video assisted thoracoscopy and all that, right? Okay, so Right. Any questions you want to ask? Rather than sending all these chat and all these questions online, and why don't you ask questions, direct questions? Make a lecture එක කරද්දී අර අතුස්සන අයම මට නම් පේන්නෙත් නෑ. I am not, because you have to interrupt, and if you have a question, you should ask questions, right? Rather than hands up කරවම මේව වැටෙනවා මට නම් මේ දෙකක් කරන්න බෑ lecture එක කරන වෙලාව. Right? Better to ask questions directly, නේ? So you are final year students. Right. Any questions you want to ask?
Sir? Sir, when do we have to do pleurodesis?
Pleurodesis, it's basically, again, that is for patients with malignant pleural effusions, right? Suppose if the patient is having lung secondaries or lung primary, which was treated, and if the patient is coming with recurrent pleural effusions, right? So that would be very cumbersome for the patient, isn't it? Right? And difficulty in breathing and all that. So in those situations, you have to go for pleurodesis. Right? Pleurodesis, you can use either tetracycline. You drain it and you insert talc or tetracycline to the pleural cavity. And those are sclerosing agents, and then the two pleurae will become adhered to one another. Right? So in that case, patient will not have a pleural space basically, and because that there won't be a pleural effusion. So it is usually being done for malignant pleural effusions. Any other questions?
So could I know the reason for that upper zone of opacification in first X-ray? Right, upper zone opacification.
Just ignore about that. This is a chest X-ray which I downloaded from the internet. Right? I just wanted to show you the pleural effusion. Just
okay,
ignore about the right apical area. Right? Just to create the scenario, I downloaded the chest X-ray. Right?
Sir.
Yes.
Sir, when we are answering about opacifications as in that X-ray, how to say it is zones or lobes? How to answer that?
So in a chest X-ray, you have to mention the lobes, right? Upper lobe, middle lobe, or lower lobe. Clinically, it has to be upper zone, middle zone, or lower zone, right? When you take the right chest X-ray, right lung, right? If the right heart border is obliterated, it is the right middle lobe. If the diaphragmatic border is obliterated, then it is to be the right lower lobe, right? So that is by using a PA chest X-ray, right? So other thing you can do is you can do a right lateral chest X-ray, right? And then I think I showed those X-rays at the beginning, right? So you draw a line along the hilum and then a sort of a transverse line as well, right? I don't have X-ray like that. And then if it is above that transverse line, it is the upper lobe, and if it is between the transverse line and the oblique line, it has to be the middle lobe, and if it is below the oblique line, it is the lower lobe. So when it comes to the left lung, again, if the left heart border is obliterated, it is the lingular lobe, and the left diaphragm is obliterated, margins are obliterated, then it has to be the left lower lobe. Right? So clinically, when you are presenting, you have to mention whether it is in the upper zone, middle zone, or lower zone. Right? So because when you are examining a patient, it will be difficult to say this is coming from a particular lobo zone, right? So in lobo from a particular lobe. So because of that, you instead of using lobes, you use the term zones. Right?
Thank you, sir.
Right. Any questions?
So for an ultrasound to diagnose a pleural effusion, can we use ultrasound, the volume lesser than 300 or?
It should be lesser than 300 definitely. So I'm not 100% sure about the volume. Maybe I at least 200 or less than that. You don't need 300 milliliters to go ahead with the chest X-ray. That is why when we have patients with dengue, we do ultrasound scan of the chest to detect pleural effusions, isn't it? Rather than doing chest X-rays.
Yes.
It has to be 200 or 200 when known. I'm not sure.
Thank you, sir.
So can you explain a bit about subpulmonic pleural effusion?
So again, subpulmonic pleural effusions, then there will be accumulation of fluid. Again, that clinically what to see is something like when you do the chest X-ray, so you will see in addition to the fluid, the costophrenic angles and all that, you might see a elevated hemidiaphragm as well on that particular side, right? So that can be due to a sort of a right or left lower lobe pneumonia or something happening from the abdominal cavity as well, something like a liver abscess, right? So that can lead to subpulmonic pleural effusion. Anything else?
So in this patient, is there a place for a MON to test in the first place?
With the short history and all that, right? And a white cell count of 18,000, basically I would not request for a MAN to test. And the patient is having right-sided pleural effusion with a right lower lobe pneumonia possibly, right? And I will not ask for a MAN to test. And inflammatory markers are very high and all that. CRP is very high. Even though I am not go for a this thing is again. So suppose if the patient is having a positive MAN2, right? Clinically, this cannot be due to tuberculosis, right? So the right just because it's a short history and all that. Other important thing is again for MAN2 test and all that. So we need to call for a different team, and those days we had to send patients to Tasim clinic to get the MAN2 done. And I am not. I will not ask for a MAN2 test in this patient.
Thank you, sir.
If the patient is not responding to treatment and all that, and if the patient's fever is persisting and all that, so then definitely we have to ask for a MAN2 test, but not in the acute setup at this stage. Right. Anything else?
Sir, is there any difference between the term parapneumonic effusion and sympneumonic effusion?
Parapneumonic and sympneumonic effusions, it's again the meaning is basically same. Yes.
Sir.
In the diagnosis of exudate or transudate type, usually we use light criteria as we discussed in this question. So in but if pleural fluid protein is more than 35 or something, can we itself can be associated? It is exudate. Can we take that?
If it is more than 30, yes, again we can use if the pleural fluid protein concentration is more than 30 grams per liter. Again, it's basically we take it as exudative type of pleural effusion. Apart from the light criteria, so we can use that as well.
In that sense, we have to support it from light criteria, or then we get otherwise only from protein analysis we can proceed it.
So usually may kakhari tibunot. So if it is a transudative type of pleural effusion, then usually it's pleural protein content concentration should be less than 3, right? And all these ratios will be very low. So if it is transudative type of pleural effusion. So you will see when we do that, we do pleural aspiration analysis, pleural fluid analysis on a patient coming with pleural effusion due to congestive cardiac failure. Then the protein will be very low, right? The ratios will be very low, right? So if it is a sort of a exudate, then definitely all these, most of the time, all these criteria will be fulfilled. That pleural protein content will be more than 30, and then the ratios will be higher than 0.6 and 0.5. The problem is now usually we do not do LDH levels, isn't it? So in our setup, we will not have facilities to do LDH on each and every patient, right? So in that case, sometimes you have to do only by the pleural fluid protein concentration.
So in pulmonary embolism, can we expect exudate as well as transudate effusion?
Usually what they say is exudative type of pleural effusion. Transudate, I'm not sure. So usually when it comes to pulmonary embolism, usually it is hemorrhagic, right? So if that to happen, patient should have a huge pulmonary embolism. Right? So then the patient will have all the other features of pulmonary embolism, hypoxia and all that, right? Because whether it is exudative, transudative, the pulmonary embolism can cause hemorrhagic kind of pleural effusion. Trauma, pulmonary embolism, malignancy, plus or minus tuberculosis can lead to hemorrhagic type of pleural effusion.
Thank you.
Right.
So in this patient, can we do TB PCR in pleural fluid analysis?
Again, TB, PCR, and ADA and all that. So if we are suspecting tuberculosis, yes. So we have to do TB, PCR, and ADA and all that, right? In ideal setup, if all the investigation, if you can do all the investigations, of course, you can go ahead and ask for ADA and TB, PCR, and all that. But with this history and all that, I don't think this looks like, it doesn't look like tuberculosis. So straight away, in our kind of a setup, I would not request for TB, PCR, and ADA as well. Yeah, for each and every patient, if you without thinking about a most likely diagnosis, if we start doing all the investigations in our setup, so we will be in trouble. So ADA, again, the relatives have to get it done from the private sector and expensive. TB, PCR, and more or less same. I don't think we are doing.
Sir.
Yes.
In the previously shown effusion X-ray, as there is a huge effusion and no airborne program, why go to the diagnosis of parapneumonic effusion?
So again, I say, now this test X-ray was downloaded for this case scenario from the internet, right? So in addition, now patient is having a pleural effusion, right? So the complete diagnosis, you have to go through, you have to look at the case scenario as well. Patient presented with cough and fever and difficulty in breathing. And when you do the chest X-ray, there is evidence of right-sided pleural effusion. Right, so then the most likely complete diagnosis is right lower lobe pneumonia leading to parapneumonic effusion. Isn't it?
Okay, okay, so, sir. Thank you.
Patient, when you have to go, you have to take the history as well. So someone give if you are given just the chest X-ray alone, then the radiological diagnosis would be right-sided pleural effusion, right? But with the history, then you have to suspect right lower lobe pneumonia leading to parapneumonic effusion. So that is what we normally see in our setup, isn't it?
Thank you, sir.
Right. Anything else?
So is it possible to us to see protein count greater than 35 in a patient with transudative type of pleural effusion who is on diuretics?
I didn't get you very clearly.
Is it possible to us to see protein count greater than 35 in a transudate type of effusion in a patient who is on diuretics?
So you said protein count more than 30 in a patient with CCF and while on diuretics. But can you repeat the question again?
Yes, so one of my colleagues also asked something about this scenario. Protein count, if it is greater than 35, it does not necessarily means exudative type of effusion. If I say so, is it correct or not?
Right. Now, so when someone is preparing a MCQ or to answer your question, right? I think we have to stick to the Kumar and Clark. So what does the Kumar and Clark say? So Kumar and Clark mentioned about light criteria as well as the protein count more than 3 grams per 3 grams per liter, 30 grams per liter. So indicative of a exudative type of pleural effusion. So when we are preparing questions and when we are going through answer script, so if there's any problem, usually we go through the Kumar and Clark. So what does the Kumar and Clark say? That is our Bible, isn't it? Or Tripitaka or Bible or anything, right? So if now when you go through the Kumar and Clark, if it is more than 30 grams per liter, then it has to be a exudative type of pleural effusion. ඒක තමයි answer එක විදිහට ගන්න. ඔච්චර ලොකු දේවල් අහන්නේ නැහැ දරුවනේ. So when it comes to exam and all that, so they will not complicate things. Right? So giving diuretics and all that මං හිතන්නේ එච්චර ලොකුවට අහන්නේ නැහැ. මම නම් දැකලා නැහැ. I haven't seen those type of questions. ඊට වැඩිය so people will they will not ask straightforward questions like congestive cardiac failure and transudative pleural effusions, right? But ඔය වගේ එකක් නම් අහන එකක් නේ මම හිතන්නේ.
Sir, I have a question.
Yes.
Sir, if in clinical practice,
Yes,
sir, if someone develop bilateral pleural effusions, visible on chest X-rays, like middle or something, not only like in this case, first X-ray, if it's bilateral, how we are going to think about the management plan? So if we are going to do the diagnosis, first we have after doing diagnostic aspiration, it came as exudative, we most likely parapneumonic effusion. If we are going to manage that patient, sir, are we going to aspirate into all of the fluid we are going to aspirate, or something we have to by time to time we have to aspirate it?
So ideally speaking, we have to aspirate as much as possible, right? As much as possible. Now, so this is a sort of a very gray area. So what I would suggest is, if it is exudative type of pleural effusion, we should try and drain as much as possible. So otherwise, what can happen is sometimes rarely it can become a sort of an insistent pleural effusion, right? So in what setup, however much you try, so you will not be able to drain all the fluids. So then it has to be done under ultrasound guided aspiration. So what is කරන්න හරි අමාරුයි. Right? So most important thing is, number one, you have to find out whether there is any indication to put a IC tube drainage, like pH and gram stain, right? And then microscopy and all that, right? And the protein count and the sugar level and all that, right? So if there is no indication, basically what they tell us is to treat the patient with antibiotics and all that, and usually patients should respond within 1 week. Right? So in that case, if there is no indication to put a IC tube drainage, we can still treat the patient with antibiotics and see the response. But very rarely, or most of the time, I think, if you do not drain all the fluid, if it is a significant pleural effusion, exudative type, so they can end up having insistent pleural effusions. Okay, very difficult scenario in clinical practice. So I think in your exam setup, you have to stick to that. So if there is no indication to put an IC tube, you can treat the cause with medications. So tuberculosis, anti-TB medications. Parapneumonic pleural effusion, you have to treat with IV antibiotics.
Yes, sir. Thank you, sir.
Right. It's very difficult to treat pleural effusions. So if it is straightforward tuberculosis, very lazy. So if it is a parapneumonic effusion, right, exudative, but still the patient is responding to antibiotics, very lazy. If the patient is having a pleural effusion, not responding to treatment, and then insisted pleural effusion empyema, you will be in trouble, right? Ultimately, you have to send the patient to Valisara, and you have to get you have to ask Dr. Damika Rasnayaka to assist us with the vet. Scenario. Something like in a SBA type of question, if people say there are a lot of hyperstrands and insisted pleural effusion not responding to treatment, next step in management, that answer. Yeah? Right. Anything else?
So, in pleural effusions in dengue patients, how are we going to classify it as transudative or exudative?
Right. So when they develop pleural effusions, right? So when they develop pleural effusions, now what would be their platelet count? Very low.
Very low.
Right. So do you want to put a needle in and take fluid from a dengue patient? No. I haven't even thought about doing a pleural aspiration and assessing whether the patient is having transudative or exudative type pleural effusion. So usually when they develop pleural effusions and ascites, I don't even get the patient to sit up to check for postural hypotension. I just ask them to lie on the bed, right? And also it has to be a transudative type of pleural effusion, not exudative. I'm not 100% sure. Right? Probably no one might have analyzed pleural fluid from a patient with dengue. Usually it lasts only for about 48 hours. Right?
So moreover, they develop pleural effusion due to increased permeability, vascular permeability.
Then it has to be transudate.
Yes.
I haven't even thought about whether it is transudate or exudate, because it disappears within 48 hours. Right? So if you look after the patient during that period, that within that 48 hours, everything would be all right. Right? So I am not sure about whether it is a transudate or exudate. It has to be transudate. Protein sharing, I am not sure. their albumin is getting low, so so I will check that. Any questions? Right. So are you all going to come to the universities tomorrow? To the hostels and all that? So when I going to come back? When I going to come to the faculty?
Tomorrow onwards, sir.
Tomorrow?
Tomorrow onwards.
How's the day there?
Hitta, sir.
Right. So and the appointments will be started on Monday.
Yes, sir.
Yes, sir.
Right. Okay. So shall I conclude the meeting then? So we will see you on Monday morning, right?
Okay, sir.
Okay, sir. Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.